In this video, we are going to cover flowcharts and tables from the topic of hypopituitarism. It is defined as a complex syndrome in which there is total or partial loss of release of hormone from the anterior pituitary or the posterior pituitary. So let us start with table 1. Etiologies of hypopituitarism. So this could be because of development or structural cause like the midline cerebral defect syndrome, pituitary dysplasia or aplasia, primary empty sella syndrome which could be seen in the MRI, or congenital hypothalamic disorders like septo-optic dysplasia, Prader-Willi syndrome, Bardet-Biedl syndrome or Kalman syndrome. Other cause could be congenital CNS mass or encephalocele. Genetic cause include loss of transcription factor, and this could lead to combined or isolated pituitary hormone deficiencies. Traumatic cause include surgical resection when you are operating for any primary pituitary tumor, or radiotherapy damage or head injuries. Neoplastic causes could be primary cause or secondary cause. Primary cause in which tumor is present inside the pituitary, like the pituitary adenoma, or other cause like paracellular mass, like germinoma, ependymoma, or glioma, or Rathke's cyst, craniopharyngioma, hypothalamic hamartoma, gangliocytoma, or secondary causes like pituitary metastasis from breast, lung, or colon cancer. Other carcinomas include lymphoma, leukemia, or meningioma. Infiltrative and inflammatory causes include lymphocytic hypophysitis, hemochromatosis, sarcoidosis, histiocytosis X, granulomatous hypophysitis, transcription factor antibodies, or immunotherapy like CTLO4 inhibitors. Then, vascular causes include pituitary apoplexy, in which patient is complaining of very severe headache. Then, and other pregnancy related causes like infarction with diabetes or postpartum necrosis, like the Sheehan syndrome. Then, other vascular cause is subarachnoid hemorrhage or sickle cell disease, in which there is thrombosis inside the vessel, or arteritis or snake bite venom, like the Russell's viper venom. Then cause could be infectious one, like fungal cause like histoplasmosis, parasitic cause like toxoplasmosis, and in India, the common cause is tuberculosis, or it could be because of pneumocystis infection. And drugs like CTLO4 inhibitors, PD-L1 inhibitors, or PD-1 inhibitors. Now coming to table 2, which is tests for pituitary sufficiency. So from this table, just remember the hormone and the test that is used. So, specifically for growth hormone and ACTH, both of these hormones are not released continuously, and that is why you need to do certain provocative test. And remember the name of this test. So, for growth hormone, the tests are insulin tolerance test and glucagon test, GHRH and L-arginine test, ghrelin receptor agonist test, and L-DOPA test. And among this, in clinical practice, we commonly do L-arginine test and L-DOPA test. You do not need to remember the dosages of any of the tests from this until unless you are giving INSS endocrinology. For ACTH, the tests are insulin tolerance test, corticotrophin releasing hormone test, metairopin test, standard ACTH stimulation test, low dose ACTH test, and 3 days ACTH stimulation test. Now, coming to other hormones, for prolactin, it is interesting that we do thyrotropin releasing hormone test because TRH also stimulates the release of prolactin, and that is why in hypothyroidism as well, the levels of prolactin is high, but this level will always be less than 200 microgram. And other hormones include for TSH, for thyroid, we do T3, T4, and TSH. And other thing that we can do is thyrotropin releasing hormone test. For gonadotropins, we can do LH, FSH, or directly testosterone or estrogen, or gonadotropin releasing hormone test. And if you want to test for several hormones at once, then you can use multiple hormone panel. Now coming to hormone replacement therapy for adults with hypopituitarism. So for if the patient is having deficiency of ACTH hormone, then you will give hydrocortisone, cortisone acetate, or prednisolone. And it is because suppose if this is adrenal cortex, then The from the outermost layer, mineralocorticoid is secreted, and from the middle layer, glucocorticoid is secreted, like our cortisol. And from the innermost layer, from here, androgen is secreted. And of all these three, the mineralocorticoid, this is secreted under the influence of our serum electrolytes. Okay, and there is no control of ACTH over the mineralocorticoid, whereas this glucocorticoid, this is purely under the control of ACTH. And that is why if there is ACTH deficiency, the cortisol levels will decrease in our body, and hence you need to supplement hydrocortisone, cortisone, or prednisolone only, because mineralocorticoid secretion will be normal. And if there is deficiency of TSH, then you will give L-thyroxine. And if there is deficiency of FSH or LH, then in males you can give testosterone gels, testosterone skin patch, or testosterone depot injection. For females, we will give conjugated estrogen, progesterone, skin patches of estradiol, and for fertility, we can give menopausal gonadotrophins or SCG. And suppose if there is growth hormone deficiency, then we will give somatotropin, both in adults as well as children. But in them, the dosages will vary. And if there is posterior pituitary hormone deficiency, then we will give intranasal desmopressin. And one more thing to remember is that whenever there is loss of pituitary hormone, then the hormones go in this following order. The loss is in the following order. First thing to go is growth hormone, followed by FSH and LH, followed by TSH, followed by ACTH. And this is important because in children, the most common presentation will be dwarfism or stunting of growth, because growth hormone goes at the beginning. But in adults, because the growth is already achieved, that is, the height is already achieved, that is why the most common manifestation is loss of FSH and LH. So, adults present with features of hypogonadism. So, these are the features of adult growth hormone deficiency. They can present to you with impaired quality of life, like decreased energy and drive, poor concentration, low self esteem, or social isolation. So, what could be seen as the features of depression? It could be organic cause like growth hormone deficiency. There could be body composition changes like increase in the body fat mass, and in growth hormone deficiency, the all the body fat concentrates in the abdomen, and that is why there is increase in central adipose tissue, that is visceral fat. So central fat deposition increases. There is increase in waist to hip ratio, and there is decrease in lean body mass. Exercise capacity is markedly reduced in this patient. There is reduced maximum oxygen uptake, impaired cardiac function, or reduced muscle mass. And cardiovascular risk factors are also present, like impaired cardiac structure and function, abnormal lipid profile, decreased fibrinolytic therapy, and atherosclerosis and mental obesity. And that is why there is increase in cardiovascular risk in this patient. And in the imaging, you can see in the pituitary there could be mass or structural damage. In bone, there is reduced bone mineral density, and in the abdomen, there is excess omental adiposity. And in the lab workup, evoked growth hormone is less than 3 nanogram per ml, and there is decrease in insulin like growth factor 1 and insulin like growth factor binding protein 3. Both are low, or it could be normal, but it is mostly low. And there is increase in LDL cholesterol, and there could be concomitant gonadotrophin, TSH, or ACTH deficit, which could be seen in this patient. Now let us see the management of adults with growth hormone deficiency. So first of all, with the history that I have shown you earlier also, and with the lab values, you have to establish that patient is having growth hormone deficiency. And after that, you should be careful and you should exclude the contraindications for giving the growth hormone in this patient. If the patient is having uncontrolled diabetes, or if patient is having proliferative retinopathy, then you cannot give growth hormone to these patients. So if there is no contraindication, then you will treat the patient with growth hormone. Then after 1 month, you will recheck insulin like growth factor level in this patient. And based upon the levels of IGF-1, then you will titrate the growth hormone dose. Then after 6 months, based upon the response, you will monitor IGF-1 levels or you will discontinue the treatment. So the question that could be asked here is, what are the values, or what, based on what levels growth hormone is titrated? So the answer would be IGF-1 levels.